Hello and welcome to the University of Edinburgh's Research Insights. Thank you for joining us. My name is Hazel Lambert. I'll be your host, and we're joined this afternoon by Dr. Richard Weller and Jane, Jen, and Nick, who are off camera but making everything work. First, the techie stuff. We'd love to hear your questions, so the Q&A box is open. You can type your questions, try and keep them short, and if you see a question you'd really like me to put to Richard, then you can upvote it. That will help me to see which ones are the most popular. This event is being recorded, but your cameras and your microphones are off, so we definitely cannot see you, we cannot hear you. If there's any noisy pets or people at your door or somebody shouting your tea is ready, it won't interrupt us unless it happens in my house. Now, these events are our way to share the latest in our research with you, but we'd really like to know what kind of topics you're interested in, so you'll have a chance to tell us at the end of the session. I'll then look at the topics that come up the most often, and I'll do my best to find someone who can cover it at our last event in March. Now on to this evening's topic. Of course, we're talking COVID-19 again. It's cold and it's dark, but Richard is here to tell us why it's worth getting out into that watery bit of sunshine at lunchtime. So Richard, please join us. Please switch on your camera and your microphone and say hello.
Hazel, thanks so much. I hope you can hear me. A very nice introduction. I'm Richard Weller. I'm a dermatologist here in Edinburgh, so I spend half the week seeing patients and half the week doing research. And perhaps unusually for dermatologists, I'm just switching to share screen. My real interest has developed into not so much just the skin as the effects of sunlight and sunlight on general health. Now, most dermatologists get interested, if they're interested in sunlight at all, is what dreadful stuff it is and how it causes skin cancer. And it does. If you're a white-skinned person, sunlight is a risk factor for skin cancer. But what my research has really shown over the last 20 years is that there is a real upside to sunlight, and it's got significant health benefits. And that really brings me into the story I'm going to tell tonight, which is about sunlight and COVID. So, what is sunlight? Well, of course, the sun, here is a picture, not drawn to scale, I might say. So sunlight falls on the earth, obviously, but there's a whole range of different wavelengths of light which fall on the earth. So at the very long wavelengths, we have infrared, which causes warmth, through visible light, long red through to short blue, and then to the ultraviolet rays, which also fall on the earth, this very short wavelength radiation. Now, sunlight's had really quite significant effects on us as humans and what we look like. So those of us who are not African or not recent African are the descendants of people who left Africa about 80,000 years ago. So Homo sapiens, our species, is about 200,000 years old. And we spent the first, well, over half of our existence as a species in Africa. And we then left Africa about 80,000 years ago, and we scattered around the world. So over the last 80,000 years, we've populated the world. And of course, one of the striking things about the world is how there are different amounts of sunlight, UV radiation, on different parts of the earth. So there's a lot more sunlight down at the equator than there is up here, really on the edges of where humans live, right up here on the edge of Northern Europe. And as we left Africa and scattered around the world, our skin color has changed. It has become paler as we moved into darker parts of the world. And so it's quite striking how the skin color of different peoples around the world has really matched up to the amount of sunlight there is in those places. And what you have is there's really two competing factors driving this change of skin color. There's the benefits, what you're trying to balance up, or what evolution and selection by evolutionary fitness is balancing up, is the benefits of having pale skin against the benefits of having dark skin. So now what these benefits are is actually quite a hard thing to say, except that we know that the amount of sunlight going in, the amount of sunlight where you live basically, is a predictor of the output of the skin color coming out. So a failed Edinburgh medical student, who you may have heard of, a chap called Charles Darwin, who dropped out of the University of Edinburgh Medical School in the middle of the last century, of course, is the father of our understanding of the ideas of evolution. So I said how sunlight's got various different wavelengths. And what do these wavelengths do? Well, visible light clearly is what we see with. And then down beyond visible, you have UVA, which is the closest, which is long UVA, and then which is about 320 to 400 nanometers. And then down at about 280, 290 to 320, we have UVB. Now, UVB is responsible for the formation of vitamin D. And vitamin D is the most proven medical benefit of vitamin D, which is made by UVB wavelengths, is it prevents rickets. It's important for bone health. And we know that, 150, this is a child in Glasgow about 100 years ago, and the slum tenements in Glasgow, people having moved from agricultural existence to industrial Glasgow and other cities around Britain, were not getting much sunlight because they were living in slums and poverty and malnourishment. And there was a lot of vitamin D deficiency as a result. And 100 years ago, there were over 1,000 children in Glasgow with rickets, and the same across other industrial cities in Britain. So that's a benefit of UVB. UVB makes vitamin D, prevents rickets. My interest, though, has been in UVA, and I have described over the last 20 years another benefit of sunlight, which is that the UVA wavelengths of sunlight release a substance called nitric oxide from the skin. And what that does is NO is released from the skin by UVA, and NO is very important for regulation of blood pressure. Now blood pressure, high blood pressure is the biggest killer in the world today, because high blood pressure makes you more likely to have a stroke or a heart attack. And sunlight releases NO, which lowers blood pressure. We did various experiments here, shining UVA at volunteers, and we showed it lowered blood pressure, and we've carried on doing this work, and we've shown that the seasonal variation, the fact there's less heart disease and less strokes in summer than in winter, goes along with the fact that blood pressure is lower in summer and winter. And we've shown that that's probably due to UV, and it's not due to temperature, and it's definitely not due to vitamin D. Now, this has caused quite a lot of interest because I'm a dermatologist, and most of my colleagues run around saying, don't go in the sunlight, it's terrible, it will cause skin cancer. My interest is actually general health and all-cause mortality, not narrowly skin cancer, but general health. And I think the benefits of sunlight greatly outweigh the risks. There's more on this story if you ever watch TED Talks. There's a TED Talk I gave with, I think it's 1.2 million hits at the moment, but I'm afraid my mother accounts for 1 million of those by herself. But there are a few other individual watchers, and a New Scientist ran a feature on my work last year. So that's kind of background to my research that I've been doing. Now, there's a few things to say here. Of course, the Earth spins round every 24 hours, night and day, and it moves around the sun every 365 days. But the Earth doesn't exactly spin round this north-south. It spins round at an angle as it moves to the sun. So it's tilted at 23.5 degrees. And this is what gives us our seasons. So as we go around the sun, if we're on that side of the sun or that other side of the sun, If we're on the sun-facing side of the Earth, that is summer. If we're on the side away, if the sun is on the opposite side to us, we have winter. Now, as rays from the sun fall on the Earth, they penetrate different thicknesses of atmosphere. So if you're down here at the bit of the Earth closest to the sun is falling directly on the Earth, and it's going through a very thin bit of atmosphere. If you're up here closer to the poles, a place like Edinburgh, for instance, particularly if you're in a place like Edinburgh now in December, the sun is low in the sky and it's going through a great deal of atmosphere because the angle it's going to the Earth on is so much shallower. And this has an effect on the wavelength of light hitting the Earth. And the reason for that is that short wavelength light is filtered out by stuff it goes through. So the shortest UV light of all, UVC, doesn't hit us down at sea level. It's really stopped by the atmosphere altogether. On top of Everest, you might be exposed to some, but not here. UVB is blocked by the atmosphere if it's thick enough. So in winter, for about 6 months of the year, there is no UVB falling on us in Edinburgh. There's no UVB now. UVA, however, does penetrate the atmosphere. But of course, there's less sun in winter. So although we're getting UVA, there's less of it. So through the year, we have different total amounts of sunlight energy falling on us. And we have a different proportion of the amounts. No UVB, which makes vitamin D, at all in the winter 6 months, but it's there in the summer. Now, I might say, I'm talking here about physics. There's more than just the physics of light here, though. It's had big cultural effects. If you live in lovely, sunny Italy, every day is waking up in paradise. The sun shines, it's warm, the sea is warm, it's gorgeous. So what are you going to call the months? Well, they're all just lovely, aren't they? So you name them after emperors, Julius Caesar, July, or numbers, December, the 10th month. They've added a couple since, obviously, because really there's not much to differentiate them. If you live up here on the fringes of Northern Europe, though, there's real differences. You could not mistake December for July living in Edinburgh. And in fact, in Gaelic, July is Antlucha, the light month, whereas now December is Andulach, the black days. Even the names here are dictated by these huge differences in sunlight, which has these cultural effects on us, as well as some of the biological effects, which I'm going to show you. So, a lot of diseases are seasonal. They vary in how common they are by season. So here we are, here's the Prime Minister, Mr. Johnson, back in November, warning that the PM warns of COVID-19 deaths twice as bad as spring. So as we approach, this was in November, so the Prime Minister telling us correctly that he anticipated that COVID would get worse as winter came on. We know that flu gets worse in winter, so there's quite a lot of diseases are seasonal. So for instance, we know that in winter, flu is much commoner than it is in summer. And this seasonality of diseases is very interesting and actually fairly poorly understood. And here we are, this is drawn from that reputable journal, The Sun, but it doesn't mean it's untrue. This is the cases and the deaths from COVID through over the last 12 months here in Britain. So a peak in deaths down in April, dropping down to a low point over the summer. And here we are, as winter comes on, we're getting the anticipated winter rise in deaths. And you can see this, a graph from The Economist 2 weeks ago, that the northern hemisphere's up here and the southern hemisphere's down here. So this is COVID deaths. In the northern hemisphere, we had our winter peak, died away through the summer, and it's rising again now. And in the southern hemisphere, they had their winter peak, which is dying away now. So we have these quite strong seasonal effects on COVID. But what causes these effects is really not very certain. So this is, I pulled this off the Public Health England website today, factors that contribute to excess winter deaths. We are used to Well, when I was a junior doctor, there were always talks about winter bed crises. We now have bed crises all year round, actually. But certainly we know there are more people admitted to hospital with heart attacks and strokes and influenza in winter and COVID. And so this is the official government website. Seasonal factors such as weather and circulating infectious diseases. But why are infectious diseases commoner in winter is my question about that. Cold effects, housing and economic factors, but nobody is talking about light. And I think that's important. So COVID arrived at the start of this year, and I was looking at this and I was wondering about disease seasonality because it interests me. And I just thought, well, we're going to have to wait a year to see what happens because we're going to need to have a full 12 months to see what happens to COVID deaths. But then they started to release, and my interest here is really the effects of sunlight on disease. We know that sunlight reduces blood pressure and heart disease. Could sunlight also reduce COVID deaths? And it seemed a bit of a long shot to start with. Except by about March of this year, March or April, the data started to come out that if you had heart disease or high blood pressure or diabetes, you were more likely to die of COVID. Now, this really was interesting to me because I know that sunlight reduces blood pressure, it reduces heart disease, and we've got some preliminary data also showing it's got beneficial effects on type 2 diabetes. So I wondered perhaps if we could do something to look at this. And the other thing that happened in March, April of this year was in America, they began releasing data on deaths all around America from COVID. And the great thing about America is it's a big place. And that means it covers a lot of different, there's a difference in the amount of UV that falls over America. So, you know, Florida is very different from Maine. You know, Texas is different from Washington State. So they were starting to release data, and I thought, gosh, I wonder if he is going to give us a window into what are the effects of ultraviolet, of sunlight, on COVID deaths. So I contacted my colleague Chris Dibben here at the university. So Chris is a geographer. But he's a geographer who does sums. He studies really environmental effects on health. And in his research group, he's got the guys who do the heavy lifting, Mark Cherry and Tom Clemens, who are both postdoctoral researchers of his and real maths whizzes. And I said to Chris, you know, do you think we can look at this? How do we do the data? And he really, with his team, set about exploring these ideas. So Chris predominantly and the group did about 2 months of analysis trying to determining whether sunlight might have an effect on COVID deaths. So I'm going to outline really the way we approached this. So first of all, we needed to look at COVID deaths, and conveniently in America, they register deaths with COVID on the death certificate at county level. So America is made up of 50 states, as we know, but it's divided up also into about 3,000 counties. So that's a smaller administrative level within the state. So there's 3,000 counties, and they record deaths from COVID at county level. So that was our outcome, deaths. We're interested in COVID deaths. And the advantage from doing modeling of disease of death is it's a very robust indicator. You're either dead or you're not dead. There's no kind of gray scales. It's an all or nothing event. And we then looked at the amount of UV at each of these counties. So you've got 3,000 counties in America, but from satellite data, we can tell how much UV is falling on the Earth, and also what wavelengths of UV are falling on the Earth. So what we do is from satellite data, we know the amount of UV falling on the outer atmosphere. And we can then do corrections for the amount of water in the atmosphere, for the ozone in the atmosphere, and also how thick the atmosphere is at that point. and you can do mathematical corrections, and that converts that UV on the outer atmosphere into a number, the energy and the wavelengths falling on the Earth beneath. So 3,000 counties, all of them with the COVID deaths. But what we then did was as I said before, you need to have UVB, the short wavelength UV, to make vitamin D. Now, we were collecting data from January to April, and basically we excluded about 20% of those counties, all of them down here in the southern part of the United States, where there was enough UV of the UVB wavelengths to make vitamin D. So we removed these 20% of those counties, about 500 counties, from the analysis. So we only looked at the counties in what we call their vitamin D winter. So these are counties in America which are receiving UVA, the nitric oxide forming wavelengths, but will not make vitamin D. So vitamin D winter. And we then looked, we could then match up the amount of UV at each spot with the COVID deaths. Well, that's the broad idea, but America is a big place and it's very different. And you need to take several other what are called confounding factors into account. So we're looking at deaths, but quite a lot has to happen between being healthy and dying of COVID. The first thing is you have to meet somebody with COVID. You then have to be infected with COVID. You have to get sick with COVID. And ultimately, you have to die of COVID. So there's quite a lot of steps from health to death from COVID. And different factors affect how likely each of those steps is to happen. And you have to take those into account. So Chris did this, it's a hugely complex, it's called the zero inflated negative binomial model, horribly long terms. Basically, what you do is you need to, first of all, account for your risk of catching COVID. So at each county, we looked at the population density and what proportion of the population has COVID. So if you live in Manhattan, you're bumping into people every minute of the day. It's incredibly densely populated. If you live in North Dakota, you see another human being once a month. And if there's not much COVID floating around in North Dakota, that human being who you rarely bump into is unlikely to have it. Whereas if you're in Manhattan in March, population is incredibly densely packed and 10% of them have got COVID. So you first of all do a correction about how likely you are to bump into somebody with COVID. And we also throw in a factor for transports. You know, in North Dakota, you're driving around in your great big truck, never meeting anybody. In Manhattan, you're on the subway, meeting lots of people. So we also threw in a public transport factor. So that's the first correction, this zero inflation. What are your risks of meeting somebody with COVID? Having met somebody with COVID and acquired the infection, what are your risks of dying of it? And we know that there are other factors that affect how likely you are to get sick with COVID, and you need to correct for these. So the number one, of course, is age. We know that age is the biggest predictor of bad outcomes from COVID. So we look at the age structure, we look at ethnicity, how many African Americans, white Americans, and deprivation indices. And then throw in a few random effects, various other things, and then we can compare. And what we show is in America, as the average environmental UV rises from 600 to 800 joules per centimeter squared, your risk of dying from COVID halves. It drops from about 65 down to about 35. Great. We then thought, well, let's go and do this somewhere else. So we then moved to England. Now in England, we collect data slightly differently. We don't have counties, we have units called MSOAs. We collect our demographic data differently. We collect our age structures differently, ethnicity is collected differently. Nonetheless, we collected and we could repeat the analysis and it showed just the same thing. A rise of 350 to 450 causes a halving of deaths from COVID in Britain. And we then went to Italy. Now in Italy, they didn't record COVID deaths. What we looked at excess deaths over expected. And the same thing, a rise of 600 to 800 and a halving of deaths in Italy. So, conclusions. UVA correlates with reduced COVID-19 mortality. Now, this is not proof that sunlight prevents COVID. It's saying that in places with more sunlight, there are less COVID deaths. It suggests that maybe sunlight reduces COVID, but of course the only way to show it would be to actually deliberately do a clinical trial like they've done with the vaccines and give some people sunlight and not the other people. This is a vitamin D independent effect. We were looking at wavelengths that don't make vitamin D. So vitamin D may have benefits on COVID. We haven't shown them, but what we've shown is that sunlight separately from vitamin D correlates with less COVID deaths. And we've shown this in 3 independent data sets. So mechanisms, well, my interest, of course, is in nitric oxide. And there's good evidence for thinking that nitric oxide, which is released from the skin by NO, might reduce COVID deaths, because we know that nitric oxide prevents the SARS-CoV virus binding to its ACE2 receptor. It interferes with it. And also sunlight and nitric oxide improve cardiovascular health, and those are risk factors for COVID. Well, so what? What comes from this? Well, I'd say the first thing, one of the really striking things about COVID is how much more at risk people with darker skin have been. So this is a picture of the British doctors who have died of COVID until September of this year. So 45% of doctors in Britain are non-white. Of the doctors who've died of COVID, 3 of them have been white. Dr. Wakeham, Dr. Spanagy and Dr. Wood. So 3 of the British doctors who've died of COVID have been white, despite the fact they make up 55% of the workforce. So this really striking danger if you've got darker skin. I just briefly introduced the fact that as man scattered around the world, our skin pigment adapted to where we worked. 2 papers out last year showing how quickly this happened. So you may have seen on the BBC website, they did DNA analysis on Cheddar Man, one of the first Stone Age hunter-gatherers in Cheddar Gorge from 9,000 years ago, and it showed you brown-black skin and blue eyes. A paper from Denmark, this time last year, from a 5,500-year-old Stone Age hunter-gatherer, just the same thing, brown-black skin. And yet when Caesar arrives, only 3,000 years later, he meets white Anglo-Saxons, Iron Age. So in 200 generations, we go from brown-black skin to white skin. And why is this? And I wonder if SARS is giving us maybe one of the reasons that our skin has got paler as people have moved up to Northern Europe is in some way, I wonder if infection might have driven that. And we're not seeing the high deaths in Africa. The other thing last year, I was getting very frustrated. All these things out saying the government complaining about people being on the beaches. They shouldn't be on the beaches in summer. And I was thinking, actually, yes, you should be on the beaches in the summer. But of course, because we've not been published, we can't talk about it. We're saying go outside for ventilation, for airflow to reduce your risk of catching COVID. I think our data suggests that actually you should be outside, not just because the open air blows the virus away, but because the sunlight there will reduce your COVID risks. So where are we now really? We're looking at, we're in the throes of getting this paper published, very important, frustrating process. But I think this is potentially an important public health thing. Should we be encouraging people to get more sunlight to reduce risk of COVID? So thank you.
Thank you very much, Richard. If you stop sharing your screen now, we'll both be able to come on screen together. We've got loads of questions already, and I love that one of the very first questions we have is, any chance you could use this in the admissions interviews to medical school? I love that. And it's been posted anonymously, but I think they should let you in just for asking that question. We have no control over that. Won't stop you from mentioning it in your interview. One of the reasons that we do these events is so that you can get access to this kind of content during our lockdowns. So do mention it if you get an interview. Now, Richard, also, I don't want to put your blood pressure up. He mentioned that his data is under review for publication with the Proceedings of the National Academy of Sciences. And that means that other scientists are looking at it, they review it, they then give it the thumbs up, it then gets published. This is what happens with every piece of scientific research. It's a really normal process. But Richard has presented this work to his medical colleagues, and it has received a prize for the most interesting research at the British Association of Dermatologists annual meeting. So thank you for sharing it with us, Richard. I love what you said at the end about viruses driving human evolution. Maybe viruses are the reason why some of us have paler skin than others. That's something to investigate. But we'll go straight into the questions. Really interesting one about whether or not we can boost or supplement our UVA exposure artificially. Is that possible? Does it make any difference?
Yeah, I mean, that's a really good question because, I mean, that's one of the questions I really grapple with. So I've done all this work saying sunlight helps. Well, tough. It's still December. You're still living in Scotland. What can you do about it? Because actually, I mean, we've done quite a lot of work looking at amounts of UV. So to get the equivalent of 15 minutes sunshine in June with UVA here in Edinburgh now, you would need to be outside naked for 2.5 hours
Not doing that.
a day. So I think number one, you might get arrested, not for your medical school interview, please. Number two, you'll get hypothermia. Number three, God, would death be more favourable than lying naked in Princes Street Gardens in mid-December? So really difficult. So we have been looking at this. Should we? I think you're trying to balance up a public health intervention. So if you can say to everybody, get as much sun as you can, there's a small benefit. But if everybody's doing that, a small benefit in lots of people has the same effect as a big benefit in a few people if you give UVA lamps. I don't know. We're actually working on that at the moment. And I have to say, I'm writing a grant at the moment to look at exactly that question. I do hope you'll be reviewing or commenting on the grant, because it's an absolute key question. Absolutely right.
And so when Richard's writing a grant, what he's meaning is he's trying to persuade people to give him money to do this research. Next question is from Rebecca White, and we've got lots of people that want this question asked. She says, if Black people have been exposed to more UV light, why are they and other ethnic minority groups more negatively affected by COVID-19?
Well, what's really interesting is looking at the data in Africa. So dermatologists who have been, the leaders of dermatology have been exclusively white in Britain and America. And their view of UV sunlight and its effects has been dictated entirely by what happens to people like them. So the dermatology view of sunlight is sunlight, skin cancer, bad. The view that my research leads to me is that actually skin color is a kind of biological. Skin color balances up the good and bad of sunlight based on where you live. So if white people go to live in South Africa or Australia, they get skin cancer. If dark people come to live at high latitudes, they get rickets and heart disease and everything else. And actually the view of skin is what is wrong. What causes health problems is the wrong balance of UV for your skin color. So too much or too little for your. Now, of course, you know, we move around the world now, but the importance of medicine is to be able to put in corrections for that. So I work in Ethiopia a lot. I go to Ethiopia every year for the last 10 years or so. And what is really interesting is in Ethiopia at the moment, they're getting cases of COVID, but they're not really picking up deaths from COVID. There's not a huge number of deaths from COVID. Now, it's a young country, the data is poor, but my colleagues there are not seeing the striking, overwhelmed hospitals, huge numbers of admissions that we see here. And you couldn't miss it here. And yet, dark-skinned people up here in Northern Europe are hugely getting COVID. So it does, I think to me, this is really interesting. I think COVID may be revealing to us one of the evolutionary drivers for this altered skin pigmentation as we've moved around the world.
So you can soak up more UV essentially.
Basically, yeah. And the other thing I might say is some really interesting work from Sweden, looking at redheads. So the palest of the pale are redheads. So fantastic work from Sweden, not COVID related, but people dying from any cause. What they find in Sweden is the people that get the most sunlight live longest. But if you live in a really dark area, the redheads live longer than the non-redheads. So not only has there been this driver to getting paler skin, but then a driver to actually becoming a redhead, which is why redheads are found here, right on the fringes of Europe. And we've got a preliminary signal saying maybe redheads, it looks like redheads are probably maybe less likely to die of COVID. We've been using a big data set called the UK Biobank, and there isn't quite enough data yet for it to be absolutely significant, but there's a trend we've found towards redheads being less likely to die of COVID. So redhead best,
interesting,
then white, then dark skinned.
Okay, so let's go back to the questions box. Douglas Gibson, thank you, Douglas. He says, does this mean that the proposed benefits of the Mediterranean diet are more to do with sunlight than with olives? Great question, Douglas. Thank you.
Yeah. I think a lot of benefits that we look in Southern Europe are UV related, but it's been absolutely forbidden for a dermatologist to consider that.
Yeah.
And that is because dermatologists have been white and they think, what happens to people like me? Oh gosh, skin cancer. They don't think about people who are, it's what's called unconscious bias, and it has dictated research, public policy and research findings, strikingly.
And this is where research can influence public policy, isn't it? I mean, if you have really strong data that shows this, you can say, get outside in the sun, then put your sunscreen on if you're pale-skinned, but it's pale-skinned, get a little bit of it. Okay, one from Judy Evans, she says, I will be forced to stay indoors after visiting my partner who's in Germany and prevented by quarantine from getting much daylight. Would a sad lamp help? So this is back to that artificial.
Yeah, the wavelength thing. This is something, I mean, these are great questions coming. I tell you, the frustrating thing is we submitted this paper at the start of July to Proceedings of the National Academy of Sciences, which is a hugely prestigious journal. Reviewers' comments coming back saying, fantastic, wonderful stuff. We just, because it's such high impact, we need to do, and 5 months later, we're still waiting. Until it's published, it is hard to get the funding, the grant money, to do the research for it to be discussed. This is important stuff. It's really important that science, I'm very enthusiastic clearly about sunlight. It is really important that somebody with a cooler head than mine comes along, looks at it dispassionately and says, have you thought about this? Have you thought about that? And that's why peer review is important. I'm more than hacked off with this journal, who've sat on this for 5 months without making a final decision. Because I want to get out there, I want other scientists to add their bit. I want to be able to raise the grant money to look at things like this, for the discussion, for the scientific process to move on, rather than being in this logjam stage at the moment.
I told you I didn't want to raise your blood pressure. You're going to have to go outside for a really long walk tomorrow. Now, this is a really interesting question. Again, it comes back to that, the UVA element. It's from an anonymous attendee, and they're asking, could UVA be used in hospitals to help critically ill COVID-19 patients until a vaccine becomes widely?
Yeah, so we've sat and thought about this. We've had these findings. We're keen that we need to move on it. There's a pandemic around it. The world has stopped. We absolutely have to sort this out. Things like this are really important. We sat and thought about, should we put in for funding to do a trial on this? I think probably by the time you're in hospital, you're needing big things like your dexamethasone vaccination beforehand. And I think the benefits from a UVA lamp, we thought that pragmatically it would be too difficult to do that study. I am bouncing it around in my head at the moment. I'm actually trying to get some of the preliminary data about how much nitric oxide is released with different skin types and wavelengths at the moment to feed into that.
And that's one of the things that's so challenging, isn't it? You can't put people in a cupboard and shut them away from sunlight. So
Yeah, I know, exactly right. And
yeah.
it's hard to conceal what happens here.
Yeah. So I think we've got time for one or two more questions. Another one, oh, it just zipped off my screen. Where's it gone? About Canada. So are COVID deaths decreased also in cold weather, even with some sunlight? For example, in Canada in the winter. Do you have any?
So it's very important to pick apart cold and UV. So we haven't been able to do it with our studies on COVID, but we published a paper earlier on this year where we looked at blood pressure and sunlight. Now we know that blood pressure is lower in summer than winter. And in the past, so dermatologists have been desperate not to find any benefits to sunlight because that would be too shocking. So they've been running around just, I don't want to see, hear, or think about this. And so although dermatologists have grudgingly accepted the fact that people are healthier in summer, they've said it's all vitamin D and it's all temperature. Well, vitamin D is proven to boost the bone health benefits, not much more, certainly no benefits on heart disease. So we did a big study rather similar to this study, but we looked at blood pressure in 340,000 Americans over 3 years in America. And again, the great thing is if you live in Salt Lake City, it's hot and it's low, so it's sunny and hot. If you live in Denver, it's sunny and it's cool. And because we got 340,000 people over 3 years, we could pick apart the effects of temperature and light, UV radiation, on blood pressure. And we showed that about half the summer fall in blood pressure is due to temperature, but about half is due to UV alone. So certainly for blood pressure, that's got an effect. I'm not sure about the COVID effect. That's going to be, we need bigger data. We need bigger data.
And the most popular question just now is about sun exposure. I know you mentioned that briefly, but Theo is asking, thanks for your question, Theo, how much sun exposure, minutes per day, will show the kind of beneficial effects that you're talking about, if it's possible.
I am delighted that was your top question, because the grant application I'm writing at the moment, if someone will just give me the money to do, I'm applying for the Medical Research Council, the research funding bodies we have here. That's exactly the question we need to know. Now, we know about sunlight making vitamin D, but actually there's benefits to sunlight separate from vitamin D. And the problem is, I give a talk about sunlight and its health benefits, and it's not just vitamin D, these other pathways too. And people come away saying, gosh, I must go and have my vitamin D tablets. It's like people saying Hoover instead of vacuum cleaner. Sunlight's health benefits, people think vitamin D, and they, even when you give a talk saying it's not. So we know about how much you need to make vitamin D. We don't know how much you need to get the other benefits. And guidelines at the moment about, dermatologists grudgingly accepting a bit of benefits to sunlight. They talk about how much you need to make vitamin D. There's more to sunlight than just vitamin D. And I don't know yet, but I'm hoping I can come back to you next year and tell you.
Honestly, I think that we could talk about this all evening, but I'm really keen that we finish on time. So thank you everyone so much for all your questions. And Richard, I think I might hold you to that. I think we should try and do this again next year, and you can come back and tell us where you are and whether you won that grant funding and whether we should all be sitting under lamps all winter. So Richard's been talking about COVID-19. The other big news this week, obviously, is that the first people in the UK have had their vaccine. And this is one of those really rare historic moments in science. It's an incredible achievement. But we also know that people have questions about it. So I'll be hosting a session between 5 and 6 tomorrow on Instagram from at Edinburgh Medical School. So if you want to come and ask us questions there, there's an opportunity. We've got some experts lined up. There's also lots of trusted sources of information about vaccines out there. Immunology.org is good, and the Royal Society of Chemistry has a really good explainer. So look for stuff that's based on sound science and evidence. And I know
can I just add that very fortunately, because I see patients several days a week, and a lot of them, I had the vaccine yesterday. I feel like Superman. I feel so fortunate.
I'm so jealous. I want to have it. So our next session is going to be live from a lab, fingers crossed, at the Roslin Institute in January, and we'll cover genome editing. I'm going to put up in a slide in a couple of minutes that goes to menti.com. So we'll leave it there. If you go to menti.com and put in the code, you'll be able to tell us what kind of topics you would like to see us cover at our last event in March. So thank you very much, Richard. Thank you to the comms team in the background who've made all this run. Thank you to all of you for joining us and for your questions. I'm going to share my screen and get that slide up now. Fingers crossed, you can see that. So thank you all for joining us. Stay safe, stay cozy at home, and hopefully we will see you again in January.